Hello, everyone. My name is Nicole Zamora. I am the Director of Community Outreach with Catholic Funeral and Cemetery Services out of the Diocese of Sacramento. Thank you all for logging in today and joining us on our 4-week seminar series virtually. We do wish we could be there with you in person, but thanks to COVID, we're all cozy in our homes, and I won't waste any more time. I am very excited, and I have the pleasure of introducing Erica Caldwell, tonight's speaker on hospice and what is hospice, what's the importance of it, all these different things. So Erica will be with us in just a moment and start her presentation. I just want everyone to know that you do have on your panel a little hand. So it looks like a little hand. So don't raise your hand because I can't see you guys. You guys can see me, but simply just raise your hand if you have a question. There is also a chat feature, but raising of the hand will allow you to ask me a question. I will unmute you and we will do questions at the end. But if it's a burning question and you just don't want to forget, please do go ahead and ask us. If there's any questions, any problems, just let me know. I'll be your moderator for the day. So without further ado, Miss Erica Caldwell of Bristol Hospice.
Good evening, everyone. My name is Erica, and thank you, Nicole, for having me this evening. I am a community liaison and educator for Bristol Hospice, and I have to say this new world of COVID is teaching me so many new things. One is how to connect in a very personal way, also in a very virtual way. So this is a unique opportunity to speak to you in the comforts of your own home. I want you all to feel very welcomed into asking questions that you may have about hospice. I know that the word hospice is a scary word for many, and I think it's because of the misinterpretations and myths, and we'll kind of go over a few of those. But if you've heard of a myth or a misconception that you want to have a clarification on tonight, please raise your hand. Let's get those questions answered, because this is a real opportunity, like I said, in the intimacy of your own home to get these questions answered. I think it's only fair that I share a little bit about me when we're going to talk about something as intimate as hospice. I have about 17 years of experience in senior living, providing families with assistance on housing and healthcare for our seniors. And I couldn't say seniors because I'm getting so close, but 65 and older. I think it's just a vibrant and active place to be in life. And so there are a lot of wonderful things, options that you have in regards to that. And I've always been a wonderful advocate of education and finding information. So should you need services, that you have someone to go to. So I encourage all of you to be active in looking at all the options that are on healthcare as we all grow a bit older and more experienced. For me, I've learned about hospice several different ways. One is to be holding a hand and taking this journey with many seniors in the senior industry as I've supported them with housing and healthcare, and became dear friends and partners with their families and understanding what is available. Also, I've had personal experiences, one with a grandmother who I was power of attorney for, as she was diagnosed with dementia. And we walked through that journey together. I have a father who was placed on hospice after a diagnosis of cancer, and we had the blessings of being together. Was initially expected for 3 months, was giving that was his life expectancy at the time of diagnosis. And I had the pleasure of having him for 2 years on hospice. So that's something that's unique. And I look forward to sharing with you those possibilities. Although everyone's very unique. And then most recently, with the loss of my mother through COVID, and all this wealth of experience, the things I did do well and the things I didn't do well, when you're leading from your heart and maybe not a place of education and experience. So I hope to share with you a few of those items at the end of this. I'm grateful to have all of you here tonight. And let's get started on Hospice 101. I hope to define hospice for you in regards to the history, philosophy, and truly the most important piece is the eligibility of requirements for hospice. I think everyone wants to know who pays for hospice. What are those levels of care? What does that care look like? And then let's talk a little bit about the myths. The philosophy of hospice is something that is really a philosophy of care, and it's the idea that we are providing people with life-limiting illness an opportunity to have a full spectrum of support. Hospice is focused on improving the quality of life of a person and their family, and really providing them that support, and with dignity, comfort, peace, and dignity. Hospice treats the whole person, not just the disease. We focus on the needs of both the patient and the family, and I think that part's really important. As we have many caregivers that are on tonight, you're not in this by yourself. There certainly are wonderful resources and support, one of those including hospice. Excuse me, the inspiration of modern hospice was a movement that came from Dame Cicely Sanders, who worked with the terminally ill in 1948. So this is certainly not a new concept. In 1967, she created the first modern hospice at St. Christopher's Hospice in a residential and the suburb of London. We already talked a little bit about the philosophy of care, and that really is to provide comfort care versus a curative measure. Bristol Hospice will provide an expert team to care for both medical, pain management, emotional, spiritual support tailored to patients and their families. Potential triggers for eligibility, and I think this is so important as we look at when is hospice the right time, or when is it an opportunity to explore? Hospice truly means that we are looking at supporting somebody with their end-of-life desires. It certainly doesn't mean that we are going to hasten or postpone an end of life. We certainly don't have that kind of indications. What we're looking for is someone who perhaps has lost 10 pounds or more within the last 6 months. That is going to be one of those indicators. A history of pneumonia, pressure ulcers, fever, urinary tract infections are some of those unique opportunities to look at saying, is this an interest of going back to the emergency room? Do we want to continue to spend those evenings or those late hours in the emergency room for a battery of tests to get these kind of needs met? Or would we prefer to have a physician and nurse team that can come to the home? That's kind of what we look at when we are starting to look at, is hospice appropriate? Those are some of the early on indications of support that could be provided at any home, truly. Some of the more aggressive is maybe refusing food or fluids, difficulty swallowing. I think the progression of decline in activity of daily living is something we would traditionally see in someone with a diagnosis of dementia. As that client, that patient, or that loved one starts to show a decline in their daily activity, it's an opportunity to look at what supports are available to you. And one of those is hospice. Reoccurrent emergency room visits to the hospital, and hospital admissions. And none of us have had a good time when we're visiting an emergency room, regardless of our age or a disease process. So I certainly would love to see less of those visits and more comfort for our loved ones. Potential triggers of bad eligibility as we continue is also increased falls. If you have a loved one, a patient or a client, who you see has had repetitive falls, start to really show a progression and a shuffling, that's an opportunity to start to talk about that decline. And is there, again, additional supports that a program like hospice can help with? Maybe they're dependent in 3 or more activities of bathing, dressing, transferring, continence care, a change in ambulation to the bathroom. These are all indicators, and collectively, they can share with us a decline that is appropriate for us to build a team to give them a quality of life through hospice, a disability, someone requiring special care and assistance. Perhaps they're unable to care for themselves as a disease is progressing, especially rapidly. I don't want someone alone out here trying to maintain someone's care and dignity all by themselves. There certainly are expert teams to provide that support and service to you. Some abnormal lab work, that might be a cause of concern and question. I think that's probably a good place to start to explore these options, just to have your plan B in place. The reoccurrence of disease after chemotherapy and radiation, if it is not a desire to continue those curative measures of chemotherapy and radiation, then perhaps looking at hospice is another opportunity for you to build a team to provide quality of life and comfort. Of course, severe illness, although death is not imminent, and that's when I would share with you about my father, is he was ill, but again, 2 years later, I had a phenomenal team to assist me in caring for him and eliminating emergency room visits. And that's something that I think is unique to hospice, and is maybe not something that many people know, that that it does not have to be imminent. Fatal progression and progressing rapidly diseases, of course, that's where we're probably most known for hospice to come in, for those that are very sick. Hospice is made up of an interdisciplinary team. That includes, you have an RN case manager. So you have a nurse that will routinely visit you where you call home, and that could be in your traditional home. It could be in an assisted living or independent living community center. It could be in a skilled nursing center. It could be in your vacation home. You really get to choose what you call home and how we care for you. So you would have those routine visits. You'd have a hospice aide who would assist with showering and dressing and everyday ADLs like shaving and bathing. You have an attending physician who will continue to follow your case and answer any change of condition needs. You have a medical director who can support your entire team and give strong direction and what they feel is best for someone with a significant change in condition. Collaboratively, they can really assist you, and you being in the driver's seat to make these decisions for yourself or your loved one. They'll have a social worker who can help you navigate and answer questions and stand by your side. You have a spiritual team and a chaplain that is right along with you to support you in faith. We have a bereavement team to assist you after the loss of a loved one, or maybe even adjusting to understanding what that process looks like. It is a great support system once you've gone through the changes of a loved one's condition, the imminent death, and perhaps the trauma right after. I love to have a bereavement team. It certainly makes this process and understanding much easier for someone. We have a team of fantastic volunteers who get to know our patients, our loved ones, our clients, and understanding who they are, and help communicate that to the entire team so that we are really caring for a person with a great interest, faith, and is supported for who they are, not just in this moment, but a life legacy of who they are. We also, surprisingly, we use a PT and a physical therapy, occupational therapy, and we also use a dietitian to do consultations and focus on the safety and maybe special dietary needs. We're really focused on the level of comfort for someone and not necessarily a curative measure moving forward. Who pays for hospice? In this world of costs that are just rising in senior care, this is a fantastic question. Medicare Part A, for those that are 65 and older, will cover per care Medicare guidelines. Medicaid, specified by the state will cover hospice. And third-party insurances like your major medical groups will pay for hospice. And I'd like to note here that you certainly have a choice. If you've used a large medical center locally and they have provided you services, and it does not mean that you have to continue with their hospice. You can find a hospice agency that fits your needs, your faith needs, and your care needs, and your family's desires on how they want this to look like. Really take the time to look at a few hospices and decide on what would work best for you and your family. That is most important, and that has been it's been a gift from Medicare that says you certainly have the right to make that choice for yourself and your loved one. Of course, private insurance and medical benefits are also something that we do utilize in regards to hospice for those that are not 65 and older. How is hospice initiated? And when we talk about all these benefits, and perhaps someone might be on an early set, is the way I like to describe it, of looking at end-of-life support and care. So although natural progression of age in life says that we are getting older, we are getting closer to a time where we'll look at that end-of-life care need. That is the time that we can kind of look at and initiate a request. You can start by asking for a consultation, and that's simply sitting down and sharing your very specific needs, your family's goals, and seeing if hospice is something that can work together at no cost to you to benefit your loved one or yourself. It can be initiated by a referral physician, a physician's referral, I apologize. It can be by, like I mentioned before, a simple call and asking for a consultation with a hospice agency, and they can help you with that initiation. Of course, my Bristol Hospice team intake department would always be happy to help coordinate any physician's orders, any medical records, any discharge planning from a hospital, a SNF, for admission at any time. And I'm always happy to answer any questions in regards to a consultation just to have a better understanding about your specific needs. And now I'd like to talk to you, once we initiate hospice, what are the levels of care and what can I expect with those levels of care? The routine home care is just that. It's the everyday care that is supported in regards to where you currently call home or where you choose to call home. And that means wherever you choose to call home, or wherever you call home, you have a routine schedule of your team of your RN, your home health aide, your chaplain, your overseeing physician, your volunteer, and your social worker. So they will come on a routine basis. They will identify your needs. They will share with you where you are in regards to your healthcare needs, any change of condition, and any discomforts. General inpatient. This comes with acute symptoms that cannot be managed in a home or a residential setting. So this is when the care need becomes a higher level of care than what can be performed in a residential or a home at that time. This is usually a skilled nursing facility or a hospital. There are routine visits are taken care of within a skilled setting. And there are a few more requirements that take place within that skilled nursing facility setting that take place. It does not have to be long-term as well. Continuous care. Continuous care is when we find someone who has these acute symptoms that are not managed. This is when we look at providing care for 24-hour periods to meet the needs of a patient. For example, there is pain and discomfort that are not being responded by traditional medicine or medications. We will have a nurse sitting there and will continue to support a continuous care program until we can get those needs under control for that patient, because again, the philosophy is comfort and care. Respite care. Respite care is an opportunity to give caregivers who provide the majority of this care, our loved ones, an opportunity to take a break for whatever reasons that may be, maybe an onset of illness, for vacation, a family event that requires you to be away from your loved one for a period of time. We do have an opportunity to provide respite care in a skilled nursing facility. That cost is again covered by a Medicare benefit through hospice. Symptom management, we're going to manage the pain, of course, the anxiety and the agitation that comes with the uncertainties of end of life or the uncertainties that come with a diagnosis. Any shortness of breath that traditionally comes with the anxiety and the agitation, and many of those other symptoms. We are going to continue to manage them with both medication, spiritual support, and physical support. The basic principles of hospice care is to truly affirm life and quality of life. It regards dying as a normal process and a natural process. It neither hastens nor postpones death, and it relieves pain and other symptoms. It offers a tremendous amount of support and a system of care to patients and their families. An attitude towards death and dying. Each person is so unique in their view of death and their attitude towards it. And we will kind of mold those changes. Society as the main influencer has a huge impact on people's perception of death. And this is just why hospice is a scary word. Attitudes of the society towards death have been changing over time, and we're finding more acceptance in regards to the term of hospice and end-of-life planning. American society tends to deny the reality of death. Previous experiences with death certainly make it a little difficult when those have not been positive experiences. The circumstances of death, and some medical professionals view death as a failure. So we try to take those into consideration as well. There are many different religions and belief systems across the world, and we hold each one individual in regards to death and mourning. Patients have a right. Patients' rights are regulated by the hospice providers under a 2018 Medicare hospice condition of participation. These rights are handed to you at the time of admission, and we encourage you to continue to educate yourself and learn what those rights are. The very fundamental of that is you have a right to choice. You have a right to choose to be part of a hospice program and utilize those benefits and care. You also have a right to cancel it and go back to a traditional medical system should you feel that it was not the right time or the right fit for you. End of life symptoms. Most patients and families who are living with a life-threatening illness can expect to experience a multitude of physical symptoms. These symptoms are related to primary illness and also can be an adverse effect of medications or therapies. Hospice care manages a patient's symptoms to promote comfort and quality of life. That is our ultimate goal when we look at hospice. And this is where we will share some myths and misunderstandings. Hospice is a place. Hospice care is provided wherever the need exists, usually in a patient's home. Hospice care can be given in an assisted living, an ALF, a skilled nursing, which we often call a SNF, or a boarding care, which is a smaller home in our local communities to care for elders. Myth number 2, hospice is only for people with cancer. And that simply is just not true. We have a more diverse need for hospice more now than ever. Hospice model is appropriate for anyone facing end of life. More than 20% of the hospice nationwide have diagnoses other than cancer. Increasingly, hospice are also serving families coping with end-of-life stages of a chronic disease like CPOD, dementia, heart failure, and stroke. Myth number 3, hospice is only for old people. That simply is just not true. Although the majority of hospice patients are older and a bit wiser, hospice serve patients of all ages. A growing number of hospice offer clinical staff with expertise in pediatric hospice care as well. Myth number 4, hospice is only for the dying. And as I shared with you some of the qualifications or the conditions, you can certainly see that it broadens that scope. As a family-centered concept of care, hospice focuses as much on the grieving family as they do on the patient. In addition, most hospices make their grief services available to the community at large, serving schools, churches, and employees, and people just like you. Please don't hesitate should you need any kind of support, that we are here to support you with any kind of loss and grief. And we certainly know in this current COVID climate, we all are experiencing some kind of loss and grief at this time. Myth number 5, hospice can help only when family members are available to provide care. Now, of course, that's the ideal setting. We recognize that terminally ill people may live alone or with family members unable to care for them or simply live too far away. Many hospice coordinate community resources to make home care possible or to help and find alternatives where the patient can safely receive care. Hospice is only for people who don't need a high level of medical care. And this is, again, simply not true. Hospice is serious medicine. Most hospice are Medicare certified, requiring that the employed experienced medical and nursing professionals with have skills in symptom control. And this means that we are there again with a main focus of providing comfort and care to those regardless of the level of care of medical need. Myth number 7, hospice means you have to change doctors. And that again is simply just not true. You have rights, and part of those rights is right to choose. You have the right to choose a primary physician. That can be the physician you've had for the last 20 years. It can be a new physician that you've just gotten to meet and really found a close connection to. Or perhaps the physician isn't someone who you've spent much time with or you haven't had a comfortable experience with. And you have the opportunity to utilize our medical director as your primary care physician. These, again, are all your choices. Myth number 8, hospice care is expensive. Hospice services are provided for as long as a patient meets the eligibility requirements. Generally, scheduled intervals require our entire team to discuss the status of each patient and identify if this patient continues to be appropriate for their plan of care. Oh, I apologize, we went a little too far. Let's talk again about the expense in regards to hospice. Most people who use hospice care are over 65 years of age, and they are entitled to their Medicare hospice benefit. This often means there's no out-of-pocket expenditure for families or patients. Even for the younger patient who uses a private insurance that may not be covered fully, there are, again, additional services that a hospice can offer that are far less. And again, quite often, more often than not, they're at no cost.
Hey, Erica, sorry to interrupt. We lost your PowerPoint, just so you know.
Okay, let's see what happened
Sorry.
here. Thank you. Are we back on?
We are back on. Thank you.
Thank you. So we're here at myth 11, and we're talking about hospice is only for patients who have pain. Now, again, the ultimate goal is care and comfort. So we don't want just a patient who has pain. Hospice team provides comfort care that focuses on more than just pain control. Our team emphasizes that the whole person, including their emotional, spiritual, social issues that occur as one nears death. Our support is provided to the patient, to the family, and to the caregivers. Hospice is for when there is no hope in sight. Now, this one's a little tough. in regards to misunderstanding. We certainly are looking at the quality of life and the longevity of life with a natural death process. When death is in sight, there are two options. We yield to hopelessness, or we live life fully as possible until the very end. The gift of hospice is the capacity to help families see how much can be shared at the end of life through personal, spiritual connections. Many families look back on their hospice experience with gratitude, as the time was a unique opportunity to connect and share with your loved one. Hospice is designed to help families to make the most of the time together and do everything possible to promote a peaceful death. And this is one of those quotes that I think makes an impact in my life. And it says, and in the end, it is not the years in your life that count. It's the life in your years. And I think Abraham Lincoln had so many valuable quotes. This one's one that I'd like to share with you guys today. I want to thank you. And I have an opportunity to answer any questions you may have in regards to hospice, the availability, the requirements, the cost, and the initiation or admission. Does anybody have any questions I can answer for you today?
So what I will do is I'm going to, attendees will have full audio control, and you may unmute yourself if you have a question. You can also raise your hand. So Sylvia, I see that you have a question. Can you go ahead now and unmute yourself? Sorry again, if it doesn't work, if it doesn't, I will try to. Let's see if I can unmute you. Okay, technical, connected to audio. So yes, I want to unmute all. Oh no, can you guys do me a favor and put your questions in the question or in the chat? It does not appear that it, oh, there we go. You should have full control of your audio. Nope. Sylvia, do you see your audio? No, I don't see you, Sylvia. Any other questions out there? I don't see any other hands raised. Oh, Erica, I can't hear you now. Erica, can you say something? Oh, Kathy, it looks like I can hear you.
Are you going to send out the PowerPoint presentation? I tried to take notes, but she was going really fast.
Yes, we will be emailing out the PowerPoint presentation. So Erica will be able to do that. Kathy, thank you for unmuting yourself. Looks like that worked very nice. So it looks like if you look at your panel, there's a little microphone. You do have the ability to do so. Mark sent us a message via chat. Can you tell me more on how to bring the subject up with my family, Erica? That's a really good question. How do you even broach the subject with your family about hospice? We can't hear you, Erica. Can you try hitting your mute or unmute button? Okay, thank you. I'm seeing folks are saying that it has it muted. I have done. Oh my goodness, how embarrassing. Unmute all participants. Yes. Oh, Mark, it looks like you unmuted yourself. Can you try to speak to see if we can hear you?
Erica, fantastic job with a lot of great information. Thank you so much for your presentation tonight.
Okay. Okay, Erica. Okay, I have unmuted everybody. Oh my goodness, I'm not sure. And thank you, Sylvia, as well for letting me know that it's not letting you speak, but let's see what I can do. Hold on one second. Oh, there we go, Erica.
There we are. Fantastic. So yes, I'd love to answer your question or give you just a few pointers in approaching this conversation with a loved one. I really like to look at goals. What are your goals? And for a loved one, I would like to say, now, are your goals? Most of the time, the conversation will start with someone saying, I don't want to go back to the emergency room. I don't want to go back to the doctors. And that's a great time to ask, what are your goals? Are your goals to remain at home? Is your goals not to be sent out to the emergency room? And many times that's where that conversation is. Yes, those are not my goals. I want to stay home. I do not want to be in the emergency room, and I certainly don't want to die in a hospital. Those are often the conversations that are starters for us. And then it's to say, well, we have an opportunity to look at hospice and the support service that bring those service and cares to the home. Would you be interested in having a conversation about that? And that usually will lead into a conversation that says, these are my health goals for myself. What I've learned with working with those that are 65 and older, I just hate saying senior because I feel like they're just my peers and we're just at a different place. Um, we often have a conversation of what those goals are and what is available to you, and then you can make an independent choice. And I think anytime we're able to empower anybody, regardless of where they are in life or their age, it's empowering. So that's how I would initiate a conversation, is asking what our goals are. And there's often an open window when we start to discuss what we don't want.
Okay, I can see Sylvia's question here, and Sylvia has a great question. What is the average wait time for admissions? Is this something that takes a long time? You finally had that conversation with your loved one, and will there be a long, wait time? What does that look like?
So those are very individual based on needs and your interest of admissions. I will share with you if someone is hospitalized, imminent, wants to go home, those would be happening within hours, within hours and limited to within 24 hours of coordination. Someone who is looking at somebody perhaps with dementia who is showing, again, when we discuss the mobility, is becoming difficult to shower, needs additional care. Bristol Hospital we didn't discuss it today, but we have additional programs that support somebody because that's a very unique hospice patient. That is not a patient that is imminent or is quite ill physically from this disease process, but it is a disease that is not curative, and we're looking at comfort measures. So for that person, we're looking at identifying what their needs are, collaborating with the physician for that referral, that order, and then we'd be able to do admission. Traditionally, someone like that would be about 1 to 2 days. We look at large medical groups. There are some specific requirements that they have, and sometimes, unfortunately, like many referrals, we are waiting for their initiation for that. So it really would be based on the medical provider. Sometimes, like I mentioned before, time is of the essence. This is something where we have to get right the first time. And so sometimes there are some creative measures for very individualized needs that we can move in a very quick manner.
Okay. We have another question that came in, and it says, what resources are available to the family once a loved one has passed? What does that look like?
So there are numerous support groups, and I want to make sure that I share with you that these support groups are for anyone that has felt a loss or a death in their life and feels that they can benefit from it, regardless if they utilize our services or that they have an opportunity to utilize hospice in general. So we have a support group. We have a bereavement team that will check on, and they're going to check on immediately. They're also going to check on, a few weeks down the road, a few months down the road, and then within that year, we also have an opportunity to collaborate and bring all those who have experienced the loss and death in that year. We bring them together. We found great healing and the opportunity to bring those people together and to share their loved one in that loss with peers of their own. Unfortunately, this year with the COVID, it's not something that will take place, but we certainly want to, we certainly take the time to connect, even through crisis like this, and making sure that those that we have served are doing well.
Perfect. And I think to take that a little bit further, Erica, the question continues to read, directly, your loved one is on hospice. They end up passing in the home. I think this is a beautiful bridge to explain why Bristol Hospice and Catholic Funeral and Cemetery Services are on this call together, right? So for those of you on today, that is something that we at our funeral home mortuary does, right? So your loved one passes. The nurse comes in, correct me, right? If I'm wrong, Erica, the nurse would be there. The person is pronounced that they have passed, that they have expired, and then our team would be there and they could pick up your loved ones. And so that's a nice smooth handoff. And so that is something that we can work with. You would let your social worker, your care team with Bristol know that you have chosen, one of our funeral homes or any funeral home, right? But in this example, we'll say that you've chosen, let's say, St. Mary's Funeral Center. And then we would be called when that person has expired. Is that correct?
That is correct. And I just want to make sure that we're clear on the alternative. If you are not utilizing a hospice service and if your loved one passes at home, they are required to go to the coroner's office at that time. And then after that, then they are able to then be transferred to yours or their wishes in regards to into life and burial support.
Yeah, and so that's one of the reasons that we're working so closely as well too, is so that folks understand that it truly is about the wishes of the loved one and caring for the family as a whole unit, right? That makes that experience a lot not quite as harsh as being transferred then to that coroner's office, whereas that your loved one is taken into the care of that funeral home that you so choose. I don't see any other questions.
This is Kathy.
Oh, hi, Kathy.
This is Kathy.
Go ahead.
Hi, I would just like to add that we recently had a parishioner who I encouraged his sister.
Oh, no. Okay, Kathy, it looks like you're breaking up just a little bit. I got that you had a parishioner. Would you like to type us the message? It might make it a little easier.
Remember the age. Okay.
Okay, I just sent you something, Kathy, and you can just reply directly to that chat, and I will get your message, and I will go ahead and try to relay it and see if Erica and I can help you out.
I don't know how I can do that.
Oh, we can hear you right now, so go ahead. No.
Okay, now I'm unmuted. I have some fluctuating internet in my house, I guess. We have done this. It has come very, very quickly, been very responsive, very caring, and we contacted St. Mary's because the individual wanted to be cremated and buried at St. Mary's. They just said, give us a call when he dies. We don't have to do anything in advance, and they'll come and receive the body and take it to St. Mary's for cremation. And that's exactly what happened. It was just so peaceful and so consoling to know that St. Mary's was so ready to be responsive. And then after he died, we went over and made the funeral arrangements.
Well, thank you for that, Kathy. For those listening, I did not pay Kathy extra to say that. I am very happy. Thank you for sharing that your experience was great. And again, that is what Bristol and Erica at her team wants. That is what our team at St. Mary's wants, is for it to be a smooth transition and for the family to be able to help travel that journey. It's a tough journey from once you enter hospice, but having the care of Bristol there is very helpful. And then the transition into our team should be smooth, just like Kathy just mentioned. I would like to take this moment to thank Erica Caldwell and also call up Jerry Delcourt, our CEO, to kind of close us out for this evening. Jerry, if you don't mind turning on your webcam, and then there we go. So Jerry, you can, I know you will thank Erica properly and then go ahead and close us out. Thank you.
Thank you. Thank you, Nicole. Erica, I just want to say that that was wonderful. That was a lot of great information. You know, the folks at Bristol that you work with are doing a tremendous job. For those of you on the call, you should know that they have locations in Roseville and Stockton, Modesto, and also in the East Bay. I think this was a great start to our 4-part series. For those of you who are interested in joining us next week, we have Dustin McFarland. He is a local attorney, and he's going to talk about what does estate planning look like for seniors. We've had a chance to talk to him separately, and I think you're going to find him to be a very dynamic and exciting speaker, and much like Erica, with a lot of great information. And he's going to talk about a bunch of those things that I will tell you from personal experience. You say, boy, I wish we had done that when my father passed. It's, you know, the advanced health directives, it's durable power of attorney, it's what's revocable and what's irrevocable. So hopefully you'll be able to join us next Thursday. Again, we'll start at 6 o'clock. Hopefully sans the technical challenges that we had for today. So Erica, thank you again on behalf of Catholic Funeral and Cemetery Services. Nicole, thank you for hosting us. And everyone, thank you for joining us for this program tonight. And we hope to see you next week. Good night, all.
Good night. Thank you. Thank you, everybody. Same link next week. You'll be sent a reminder. If you know of someone else that would like to join us, please share that information. Thank you.
Bye-bye.